Hello and welcome to the last video of the General Examination series, General Examination number 3. And we're going to talk about in this lecture some review, like the context of the examination. So one of the things we'll mention is that yes, physical diagnosis, physical examination occurs typically after the history and you've begun forming a little bit of a differential diagnosis. But as we mentioned before, and as we discussed extensively in the second lecture, as soon as you begin introducing yourself to the patient, you begin noticing things about them that are part of your objective observation of the patient, part of your physical examination. And you don't want to ignore those things. You want to pay attention to them. You want to describe them. You want to use them to understand the situation better. With that reminder in hand, let's talk more about a personal system for performing the physical examination. Again, you need your own system. This is the beginning of what McLeod's suggests, but you're going to come up with your own system. But it's really important to be systematic and to do things the same way every time so that you don't miss anything. So we're going to talk in this lecture about things we can quantify, things we can measure that help us define what's going on with the patient. So the first aspect is consciousness. So, you can, of course, talk about, is the patient alert? Are they lethargic or sleepy? Are they comatose and completely unresponsive? You can talk about those things in that way when you're doing your general inspection of the patient, as you're introducing yourself, as you're seeing them for the first time. And begin talking to them. But it's really helpful if we can objectively document the level of consciousness. And so we use a tool like this called the Glasgow Coma Scale, where you give the patient a score for whether or not they're opening their eyes spontaneously. That would give you 4 points, or whether or not they're not opening their eyes. No response. They get 1 point for that here in the eye-opening section. The verbal response, are they able to tell you where they are and who they are? They get 5 points here. But if they can't respond, they only get 1 point there. And the best motor response is another category we'll judge. Do they obey commands with their movements? That would get them 6 points. Or do they not respond at all, even to pain? That would give them 1 point. So you do want to be able to assess consciousness. And why do we care? Why do we want to quantify it? Well, it actually does bear on their mortality, right? People who have an 8 or less are in a coma by definition. And the possibility of survival is greatly decreased in those patients. And so this really helps us understand not just are they conscious or not, but how deeply are they unconscious and what does it mean for their well-being and what's going to happen to them. And so you want to be able to use a tool like Glasgow Coma Scale where you add up the eye-opening, the verbal response, and the motor response scores, and you get an answer. The best response, they get top scores and everything, that's a 15. If they're not doing anything, they're completely unresponsive, a dead person can get a 3 on the Glasgow Coma Scale. But anything, again, 8 or less is very serious and indicates your patient has a high chance of dying and they're very deeply unconscious and they're in a coma. So again, you can use non-specific subjective terms like alert, lethargic, obtunded, stuporous, or comatose when you first meet a patient. But those could mean different things to different people, and that's why the Glasgow Coma Scale is so useful. It allows us to quantify how conscious is someone, how risky is their decrease in consciousness. All right, let's talk about hydration. Another super huge important thing we need to observe about patients, every patient, is their hydration status. Kind of along with their nutritional status, but especially their hydration status is important because our bodies are close to 70% water depending on whether you're male or female, depending on how old you are, but in that ballpark. So we are made mostly of water, and so when we're dehydrated, this is a medically significant problem. And in fact, most medical problems that occur, if dehydration exists with that problem, the hydration is the first thing you have to fix before you can fix their other problems. So we always want to be able to quantify hydration. Now again, we can grossly say, oh, they look dehydrated, but we have some specific measures we can look at. So again, all these things we just said. You have to maintain circulation. You need 1 cc of water for every kilocalorie you want to metabolize. So to nourish yourself, you need water, and we are mostly made of water. So hydration can exist in 2 different disorders, or can come into play, 2 different disorders. Dehydration, not enough water. It's kind of difficult to assess dehydration just by physical examination. You could be led astray. So we'll talk about how do you do that, because it's easy to underestimate fluid loss. And I've already said dehydration is a very significant problem. We don't want to underestimate the fluid loss. People can also be overhydrated. They can have too much water in the body. This is often more obvious than dehydration because you get swelling of the legs, you get crackles indicating swelling and edema in the lungs. It's more obvious sometimes when people are overhydrated than when they're dehydrated. So what do we look at? Let's look at dehydration. Now I know you guys are familiar with this technique of pinching the skin to estimate if somebody dehydrated or not. Okay. You can look at skin and soft tissues for sure if they're sunken eyes or they have dry mucous membranes, or loss of skin turgor is what this over here points to. We say it has tenting of the skin. When we pinch the skin up, it stays up. That's a horrible way to assess hydration, honestly. Only people who are very severely dehydrated get it. And at that point, because it's one of the last things that shows up, one of the last things that happens, your patient is in a lot of trouble by then. So you want to look at these other signs because they're more accurate in terms of assessing hydration, and they pick up dehydration earlier. So the first one, and very objective, is the weight. 1 liter of water weighs a kg. So if you know someone's baseline weight and it's down by 2 kgs, you know they're dehydrated by 2 liters if that has occurred over a very short period of time, right? Nobody loses too much fat or muscle over a day or two, but big weight changes over a day or two typically indicate fluid changes. And so weight is a very reliable way to quantify the amount of dehydration. Other things that are less objective and not as accurate, but nonetheless important, pulse rate and the quality of the pulse, right? So the faster your pulse, the more likely you are to be dehydrated, assuming nothing else is causing you to have a fast pulse. If it's weak and thready, hard to feel because the pulsations are weak, that also goes along with dehydration, again, assuming there's nothing else that explains it. But again, that's less specific than weight loss over a period of time. Blood pressure. You can measure someone's blood pressure when they're sitting down when they come into your office, but you can also do it in a laying down position, a seated position, and a standing position. This is called taking orthostatic vital signs, taking an orthostatic blood pressure. So when it falls by more than 15 millimeters of mercury, 15 points in the top number when they're upright, typically you lay them down, you measure a blood pressure, then you sit them up and leave them that way for a few minutes, usually 3 minutes, then you measure the blood pressure again. If it's more than 15 points lower for the systolic or top number, then that person is very likely to be dehydrated. Another word about that is when you find someone is dehydrated and you quantify it, make sure it reverses those signs and symptoms. Make sure when you've given them fluid before you release them to go home that the pulse is normal. Make sure that the blood pressure is now normal. Make sure that you've given them a sufficient quantity of fluid to replenish the fluid loss they've had. You may not have to give it all to them by an IV. They could maybe continue drinking at home, but you have to get them to a point where you've given them some fluid and they're able to consume the rest by mouth, or that you've reversed the process that made them dehydrated in the first place. Overhydration. Again, weight. How do we know how much fluid the patient has beyond the normal? Well, if their weight is up 3 kilos over a day or two, then they probably have 3 liters of fluid extra in their bodies. You notice it by way of edema, and that's what's being depicted in the picture there on the left. You notice that there's just an indentation left when they remove the thumb. That's pitting edema. A note that gravity pulls fluid to dependent areas, even when people aren't volume overloaded, but it supports the idea of too much fluid on board. Notice that it's not always the feet. If someone's not standing up or sitting up, then the fluid won't accumulate there. If they're laying down, it will accumulate in their lower back, and so that's where you want to check for swelling or edema. You can always check something like the jugular venous pressure. We'll talk about that more during the cardiovascular system. It's tough to check, but that also, when it's elevated, goes along with too much fluid in the body. So weight, again, for both dehydration and overhydration, fluid overload, is going to be the most reliable way to quantify how much fluid the patient has lost or how much above normal they have. All right. Now let's talk about lumps and bumps and swellings, right? One of the things that people may come to us with, one of the things we may notice as someone sits across from us as we're doing the general examination is a lump or a swelling, right? We want to describe those things. So when we notice it, or when the patient asks us about it, or when we find it as part of our examination, we want to describe it. And SpaceBit is a mnemonic to help us do that. So each letter stands for one thing we want to describe about the mass. So the first thing is the size, the next is the position, the next is attachments. Is it fixed to the underlying tissues or not? If it is, that's much more concerning for something like cancer or a malignancy. If it's not attached, that reassures us that this mass is less likely to be cancer or a malignancy. Consistency, something that's soft and more like a rubber ball, is much less concerning for cancer, say, than something that's hard and like a rock. And why do I keep saying cancer? Well, because when people have a mass, typically their first thought is, oh my gosh, is this cancer? And we want to know. We want to decide how likely is it to be a dangerous problem like cancer versus some other problem we would treat and is more likely to go away more easily. We talk about the edge. In other words, does it have a well-defined edge and a regular border? Is it easy to find the edge? If it's not easy to find the edge, we worry that it is a cancer that's grown into the underlying tissues. It may also be attached. Surface and shape. And again, a more round, regular surface and shape reassures us that this is not cancer. But if it has an irregular shape, not like a circle or an oval, but it has kind of like tentacles reaching out from the mass that are attached to the underlying tissues, we're very concerned about that. The P stands for pulsations. In that sense, it would tend to indicate a vascular mass, swollen blood vessels and such things like that. And sometimes it has a sound like a thrill or a bruit to it because the blood is flowing turbulently through there like a raging river. And so the blood makes sort of a vibration noise as it goes through. And again, a vascular mass is less concerning for cancer in most cases, though certainly cancers can cause increased blood flow to an area. But if you have a pulsating mass, those are still dangerous, right? If a blood vessel ruptures, that's dangerous. But again, they're less likely to be cancer in many cases. Inflammation is reassuring to us. We want to describe whether it's inflamed or not. And what tells us whether it's inflamed is the color. Is it red? More likely to be inflamed. Is it tender or painful? More likely to be inflamed. Is it warm? More likely to be inflamed. And again, most cancers are not inflammatory. Infections are inflammatory, so something like an abscess would give you this appearance, or a cellulitis would give you this appearance, and a cancer would not usually, though it can. And then lastly, transillumination, and that is when you shine your light, your pen torch, across the mass. Is light transmitted through it or not? If it is transmitting light, then it's more of a cystic structure. It has fluid inside and it's not solid. And again, a fluid mass can be cancer, but it's less likely to be. And so again, it's more reassuring if it's a cyst or is filled with fluid, that kind of thing. So again, we want to describe all these characteristics of a mass. When you describe a mass to me as your supervising doctor, you need to describe all of these aspects: the size, the position, the attachments, etc. So how do we do it? This diagram to the right is from McLeod's. So, this is how we would examine a mass. We'd inspect it first. Obviously, we always look with our eyes first. Then we define the size and shape with our touch, with our palpation. We're going to measure it. We're actually going to get a ruler and measure it and record those findings, maybe even draw them. We're going to palpate for tenderness. We're going to feel the skin with the back of our hand, because that's the easiest way to pick up a change in temperature. And then we're going to feel over the lump to see if it's pulsatile for a few seconds. Then we'll assess the consistency and its texture. Is it easy to depress it or not? Is it more rubbery or more hard and rocky? Is the surface smooth or lumpy and bumpy? Are the margins easy to define, or is it grown into the other tissues around it? So we try to pick up a fold of overlying skin to see whether the lump is fixed to the skin or not. We also try to move the lump in different planes, so we push it side to side and back and forth relative to the surrounding tissues to see if it's fixed to deeper structures or not. We try to compress it on one side and see if there's a bulge that occurs on the opposite side. We call this fluctuation, which would be something more, a fluid consistency would do that. And we would confirm whether or not the fluctuation is in two planes or not. Usually it indicates there's fluid there, and it could be an abscess, but it also could be a soft, fatty tumor like a lipoma. We'll auscultate. We'll put a stethoscope over the mass to see if there's any vascular bruits, and we'll also do that transillumination to see if it's hollow and filled with fluid in that way as well. That's how we examine a mass, and what we'll use to describe it by the SPACE-SPIT acronym. So let's look at lymph nodes as a specific example of a mass that people may come to you to have evaluated. One of the things that gets swollen and people report as a mass are the lymph nodes. And so we want to make note of those as part of our general examination of the patient. So here's the sequence for that. Again, it's a diagram from McLeod's, so you can look it up in McLeod's and study it from there. It might be easier to read and see in the book than it is on a slide. But nonetheless, the general principles are similar to what we just discussed for any mass. So again, these are a specific case of a mass, and there are a few particulars about the examination. So we're going to look for visible swollen lymph nodes. We're going to feel one side at a time, comparing side to side. Lymph nodes are typically distributed equally and symmetrically on both sides of the body. So we're going to compare side to side as we examine lymph nodes. We're going to assess their site, their size, all of those SPACE-SPIT criteria, and determine whether the node is fixed to deeper structures or the skin. We're going to check the consistency to see if it's an abscessed node or if it's just an enlarged lymph node that's reacting to some infection in that area. And we'll check, of course, for tenderness. Where do we start? There are lymph nodes all over the body, but the head and neck are a common place we need to examine. So when we want to examine the neck or cervical nodes and the axillary nodes, we're going to have the patient sit down and we're going to start from behind them. We'll stand behind them and we'll examine the submental nodes beneath the chin, the submandibular nodes beneath the jawline, the preauricular nodes in front of the ears, and the tonsillar nodes of the upper neck. We're going to look at the supraclavicular and deep cervical nodes that are in front of and behind the sternocleidomastoid muscle and behind the clavicle. And again, these are things you can see in terms of a diagram in McLeod's. So then we're going to palpate the axilla to see if there are nodes there, the armpit. So we have the patient relax with their arm at their side, and then we push upwards. We push our fingertips up into the apex of the axilla, and then slowly move them downward, palpating against the chest wall to try to find if there are any medial, anterior, or posterior lymph nodes in the axilla, the axillary fossa. Then we'll move down the body to examine lymph nodes into the epitrochlear nodes. These are at the elbow. We support the patient's right wrist with our left hand, and we're going to hold the partially flexed elbow with our right hand and use the thumb to feel if we can find any lymph nodes swollen there. Okay, so we use our left thumb to examine their left epitrochlear area and our right thumb to examine their right epitrochlear area. And then lastly, inguinal nodes. This is not something you'll do this semester, but there are nodes in the groin that we want to examine, and also behind the knee, the popliteal nodes. So we palpate over those to see if there are swellings or enlargement of those lymph nodes. Okay, and this is the picture from McLeod's depicting that examination. Again, notice starting behind the patient, doing one side and then the other with our hands, going from the neck down to the supraclavicular area behind the clavicle, then doing the posterior neck from in front of the patient, then going down and doing the axilla, the epitrochlear nodes, and then lastly, here's the inguinal lymph node examination. Okay, so the summary. This is what we want you to be able to do. We're finishing up general examination. You've learned the overall examination context and process, and then you've learned that you need to observe lots of things about the patient when they enter into your office. Their demeanor, their posture, their dress, their smell, their coloring, their mood, all of these things you want to make note of, their gait, all of these things. Then we're going to look at more specific things like, their hair, their mouth, their tongue, their hands, any findings there that we may notice as we shake hands, as we talk to them, as we look at them from across the room. And then we are lastly going to focus on things we can quantify. Their consciousness, let's quantify it with the Glasgow Coma Scale to see how conscious or unconscious they are. Hydration status, you want to assess this on every patient because it's one of the most important factors in health, having adequate hydration. So we quantify that again objectively using the weight of the patient. And then we move into things like lumps and bumps. We want to assess any masses that we may note or that the patient has found and wants us to look at. We're going to use the SPACE-SPIT acronym. So it's important to understand that and to be able to use it to describe masses. And then a specific application of examining masses is performing the lymph node examination, starting with the head and neck, starting from behind the patient, then moving to the front, and then moving down the body to the axilla or armpits, to the elbow where the epitrochlear nodes are, and then down to the legs, the groin area where the inguinal nodes are, and the popliteal fossa where the popliteal nodes can be found. And that's the overall scope of the general examination and what we want you guys to be able to do at the close of this semester. So, when you see the patient, you will have an impression. You want to better define that impression by specifically describing what you're seeing. You're going to make note of consciousness, hydration status, any lumps that you may see, and also do a lymph node examination. And this is going to be important for most body systems. So you want to do this with most of your patients. Always remember the general examination sequence will follow examining any part of the body. We will look first, that is inspection, Then we'll feel with our hands, palpation. Then we'll percuss or tap over it. And then lastly, we will listen with our stethoscopes, which we call auscultation in medicine. So there you have it. Thank you for paying attention to this lecture, to this series of lectures about general examination.